Good evening, good afternoon. On behalf of the ESID Clinical Working Party, I would like to welcome you to the third ESID Grand Round webinar on COVID-19 in children with a focus on management of MIS-C patients. We have an exciting 1-hour meeting. I'm your moderator, Filomeen Haerynck from the Ghent University Hospital Ghent in Belgium. And it's a great pleasure to welcome our eminent panel members. During the first part, MIS-C cases will be presented by Dr. Levi Hoste, pediatrician in training and PhD student at my lab, and Dr. Markéta Bloomfield, pediatrician and researcher at Anna Sediva's lab at Tcell University in Prague. All panel members will briefly highlight one topic on MIS-C. It's a great pleasure to welcome Alexandre Belot, who is head of the National Reference Center for Rheumatic and Autoimmune Disorders, RACE, at Pediatric Hospital at the Hospice Civils de Lyon at France, and chairing the National Network on Rare Autoimmune and Autoinflammatory Disorders of France, including the French Consortium on MIS-C. Michael Levin is professor at Pediatrics and International Child Health at Imperial College, London. He is leading the Perform and Diamonds project and coordinates the BAT study, which he will present later on. Anna Sediva is professor at the Department of Pediatric Immunology at Motol University Hospital at Prague and is also a member of the ESID Clinical Working Party Steering Committee. Marco Gattorno is professor at Pediatric Rheumatology at Gaslini Institute in Genoa, Italy. He's principal investigator of Eurofever project and ERIA project on autoinflammatory disorders. He coordinates HyperPET COVID register linked to ERN Rita, which he will present later on. And Maria Caraba works at the Department of Medicine at Grande Fondazione Maggiore Policlinico Hospital at Milan. Welcome all panel members. As this webinar has a goal to be interactive and to exchange our experience with you all, I encourage you all to ask as much as possible questions, and you can drop them in the Q&A section. Practical, technical inquiries can be asked in the chat box. So I would like to ask to Levi if he can start with the first MIS-C case and some introduction on MIS-C.
Good afternoon, good evening, everybody. My name is Levi Hoste. I'm a PhD student and a trainee in pediatric immunology in Ghent in Belgium. And I feel very honored to be able to kick off this meeting on MIS-C. I'm going to present you a brief introduction on this novel pediatric entity. Next slide, please. I have nothing to disclose. Next slide, please. As you all know, children seem to have a reduced susceptibility to COVID-19. Although formal evidence is lacking to date, multiple reports have suggested some of the hypotheses that may underlie this reduced susceptibility. For example, this paper from Steinman from last year suggested that, for example, the competition with other coronaviruses, the altered distribution of the SARS-CoV-2 receptor in the lungs, or a protective Th2 immune system might underlie a reduced susceptibility to symptomatic SARS-CoV-2 infection. Next slide, please. On the other hand, during this pandemic, we encountered a novel pediatric disease. In April and May from last year, rapid communications were spread on cohorts of children that presented with a novel inflammatory syndrome. Some of these children fulfilled some of the Kawasaki disease criteria and presented often with cardiac depression or shock and a frequent need for an intensive care unit admission. Because of the epidemiological situation at the time, a relationship with COVID-19 was immediately presumed. Next. Since these initial reports, multiple observational cohort studies have been published. And also from these reports, it was immediately clear that this novel disease entity seemed to have a link with the spread of the virus. First in Italy and other Western European countries, and later also in the UK, the US, and the rest of the world. We got to know this disease as pediatric inflammatory multisystem syndrome, or PIMS, or multisystem inflammatory syndrome in children, or MIS-C. From the disease criteria that were drafted ever since, there was always a criterion of fever and inflammation, the fact that it should concern children and that there should be multi-system involvement and a relationship with SARS-CoV-2. Next slide, please. Also, in our center, we encountered similar children, and it was in early May 2020 that this boy was admitted at the intensive care department. It was a boy of 8 years old. He is black, but had no prior medical history, besides the fact that his father and brother had been sick a few weeks ago with upper respiratory tract infection and fever. Because we did not have accessibility to PCR testing at the time, we did not have a confirmation of SARS-CoV-2 in the sibling and the father. The boy presented at the emergency department with a history of fever, a high-grade fever for 6 days, and he was feeling progressively ill. He had severe abdominal pain, had vomited twice, and had severe diarrhea. Clinically, we found that he was tachycardic, had a hypotension, he had high-grade fever, and was lethargic. He had a painful abdomen on palpation, and he had some of the disease criteria that could fit an atypical Kawasaki disease, such as cervical adenopathy, bilateral conjunctivitis, and a maculopapular exanthema. Next. In the labs, we encountered that he had a hyperleukocytosis, but that he had very low lymphocyte counts. He had a mild anemia and normal to reduced platelet counts. He had signs of inflammation in the blood with an increase of CRP and ferritin levels, and he also showed increased D-dimers. His hypotension was paralleled by increased troponin counts and an increase of proBNP, and we tested him repeatedly for SARS-CoV-2 by PCR, which were all negative. Also, other microbial cultures were negative. From the medical imaging, we learned that he had no cardiac aneurysms, but that he did have some coronary dilatation, and that especially his left ventricular ejection fraction was severely reduced. Next slide. Before I continue with our case, I'd like to present you this data from a systematic review that we conducted on this novel disease entity, PIMS or MIS-C. We systematically reviewed the first 950 cases that were published in literature, and from this overview figure you can appreciate the heterogeneity of the disease, but also its multi-system involvement. So from the disease criteria, we know that all patients present with fever, but it's very striking to see that over 85% of cases also have gastrointestinal manifestations. Cardiovascular symptoms are frequent and often lead to intensive care admission because of the hemodynamic instability. And in comparison with, for example, COVID-19 pneumonia, respiratory symptoms are not very frequent. Demographically, there seems to be a specific age group that is affected, children around 8 years of age. There are slightly more males affected, as well as some racial or ethnic minorities. Pre-existing comorbidities are not very often encountered, besides the fact that many children have overweight. Treatment is most often given under the form of intravenous infusion of immunoglobulins with or without systemic corticosteroids. Many children require supportive therapy in the form of inotropics or vasoactive medication and oxygen support. Despite the fact that this is a very severe disease, the outcome is relatively good, and we see that not many children require a long hospital stay, so they tend to stay only a median duration of 4 days on the ICU and 8 days in the hospital, and also the mortality rate is relatively little, with less than 2% of mortality. Next slide. From this disease spectrum, you can appreciate the fact that making a differential diagnosis with other pediatric diseases might be difficult, especially given that many of the symptoms and the routine laboratory features of MIS-C have very little specificity and sensitivity. It might be difficult, for example, to differentiate from Kawasaki disease, especially given that incomplete Kawasaki disease, which is a prolonged fever with only 2 or 3 of the Kawasaki disease criteria that are listed in the right corner below, might be present in many of the children presenting MIS-C. Also, other pediatric conditions such as primary or secondary HLH, systematic rheumatological diseases, or infections that present systemically might present with systemic inflammation, multi-system involvement, and prolonged fever. Next slide. So back to our case, we stabilized the boy at the emergency department, and he required PICU admission at the time. We gave him non-invasive ventilation. He had multiple fluid boluses intravenously, and we also started vasoactive medication. As was recommended at the time, we treated him with a 1 dose of IV immunoglobulins of 2 grams per kilo, and it was very striking to see that his shock completely reversed in the next few hours. Also, his other symptoms of fever and gastrointestinal symptoms recovered in the next few hours. We saw that we could stop the vasoactive medication and all oxygen support the next day, that he could be discharged from the PICU on day 2, and that 1 week later he was already home. At the time, we were still surprised when we got a phone call from the microbiologist. On day 3, they called us to say that the SARS-CoV-2 IgG was positive on the serum of our patient. This confirmed that he was recently exposed to SARS-CoV-2 and confirmed the diagnosis of Miss C. To date, he is in follow-up at our clinic. He remains asymptomatic and has a normal heart function to date. Next slide. I won't go into details of the treatment of Miss C because our next speakers will highlight this a bit further. But in any case, it is very important that you approach a patient with the so-called ABC, airway, breathing, circulation approach, and that you stabilize a child with severe illness first. Next, and still, it is recommended to give IVIGs with or without intravenous corticosteroids in these children. Only refractory disease require biological treatment at this time. Multiple reports have drafted NICE guidelines, such as one presented here. And in many children, you should consider to give, for example, aspirin, prophylactic antibiotics, and anticoagulants, depending on the situation. Next slide. Over the past year, we have learned a lot on the inflammatory responses in pediatric COVID-19. And multiple research groups have highlighted some of the immunological mechanisms that might underlie Miss C. To conclude, I'd like to present you this overview figure and show you some of these data. When a child is infected with SARS-CoV-2, he most often presents with mild respiratory infection or can remain completely asymptomatic. The hypotheses that are presented that explain this in comparison to, for example, the elderly, I have highlighted before. In any case, the host inflammatory response in these children, the majority of children, remains in check. Next slide. Of course, some children are vulnerable for a severe disease and do present with a progressive illness that, for example, progresses towards ARDS and cytokine release syndrome, the clinical picture that we see in acute COVID-19 pneumonia, for example, in elderly. Especially children with a genetic susceptibility, having pre-existing comorbidities, or for example, deficiencies in type 1 interferon can be vulnerable for such disease course. Next. On the other hand, we have got to know Miss C as a post-infection phenomenon presenting in the convalescent phase. Multiple research groups have highlighted the inflammatory cytokines that seem to be implicated in this inflammatory response, and especially a role for type 2 interferon seems to be important. More recently, different groups have highlighted the presence of a clonal expansion of T cells harboring a specific TCR receptor, the TRBV 11.2. And in any case, with adequate treatment with intravenous immunoglobulins and corticosteroids, there is a rapid reversal of this hyperinflammatory state. Nevertheless, during the acute phase, end organ damage can occur. The risk factors that are associated with the onset of Miss C remain unclear to date. And for example, demographic susceptibility seems to be present in terms of genetics, ethnicity, and also that specific age groups seem to be affected. Nevertheless, the immunopathology that underlies this susceptibility is unclear. Based on the clonal expansion of T cells, one could consider the presence of a superantigen, but as with other hypotheses, such as the presence of immune complexes pre-existing autoantibodies, or antibody-dependent enhancement, no formal evidence has been present to date. The fact that lymphocytes have an aberrant function at the onset of MIS-C is very clear, but why this is triggered in certain children and others not is not. With that, I'd like to conclude and give the word to our next speaker, who will highlight a little bit more on the differential diagnosis and the clinical presentation of MIS-C. Thank you for your attention.
Okay, good afternoon, everybody. My name is Markéta Bloomfield, and it is a great pleasure to be able to dive with you into the clinical and practical aspects on 3 cases that I prepared for you. Thank you, Levi, for the great background that you just provided us. You can go next. I have nothing to disclose. And so this afternoon, I have prepared for us 3 clinical cases to compare and to learn from. We will talk about 3 children, Anna, Brian, and Clara, and the hitch is that 2 of them will in the end be diagnosed with MIS-C, and 1 of them will end up having a completely different diagnosis. And I wonder if we can spot together which child and what it could be. So all children are previously healthy children. Anna is a 1-year-old toddler who first visited her GP at day 2 of her illness. She had a CRP of 47 milligrams per liter while being febrile. The GP thought that the diagnosis is acute tonsillitis and prescribed oral penicillin. However, this treatment did not prove to be effective, and the child returned on the 4th day with a of 107 milligrams per liter and looking significantly unwell. The child was now feverish for 4 days. She had a 40 degrees high spiking fever. She had now diarrhea, and her mother also reported that a strangely looking rash started appearing. Please, next. The rash was macular, patchy. It was all over her torso, and it was also on the extremities. She had palmar and plantar erythema. There was bilateral non-purulent conjunctivitis. She had cracked lips, strawberry tongue, but also she presented with shortness of breath. She was tachypnoic and she was coughing. Her cardiologic symptoms were also present as hypotension and tachycardia, and she was irritable, and the doctor who was admitting her to the hospital described signs of meningismus. The other child, our second child, is Brian. He is 5 years old schoolboy who arrived to the A&E on his 4th day of illness with a CRP of 75 milligrams per liter. He was also diagnosed with acute tonsillitis. His group A streptococcus antigen test was negative from the throat swab. His fever was milder. It was a maximum 38.5 degrees Celsius, but he also reported abdominal discomfort. There was the occasional vomiting. Next, please. He also presented with macular rash and palmar erythema. He also had bilateral non-purulent conjunctivitis. He had cheilitis, yet there was no strawberry tongue, no respiratory symptoms. He only had mild tachycardia, and there was no neurologic involvement. Now, Clara is a 3.5-year-old girl who arrived to the A&E on her 4th day of fever with CRP 136 milligrams per liter. The fever was rather high, up to 39 degrees. She had diarrhea. She was vomiting. Next, please. She also had erythema multiforme-like exanthema. She did have no conjunctivitis, no cheilitis. There was no strawberry tongue, but she was tachypnoic. She was tachycardiac, and she was mildly irritable. So now we're going to have our first poll question, I believe. Oh, no, sorry. Are we now going to have investigations? I would have skipped your further clues. So now we have the laboratory investigations of our children, where all 3 of them showed evidence of previous contact with SARS-CoV-2 infection, while Anna and Brian had PCR COVID-19 positive test on their arrival to the hospital. Clara did not have the PCR positivity, and all children at the time of admission had SARS-CoV-2 positive antibodies. All 3 children had normal leukocytes overall count. However, they all showed marked neutrophilia and decreased lymphocyte count. there was thrombocytopenia in Anna and Brian, whereas Clara's thrombocytes were normal. All children showed a marked increase in their inflammatory parameters, that is erythrocyte sedimentation rate, CRP, and procalcitonin. Anna also showed elevated ferritin. The others had ferritin at normal levels. The metabolic panels were remarkable for slightly decreased sodium and albumin in all of the children, but it did not require any substitutions at that time. And all the children had increased D-dimers, the most prominently in Anna and Clara. Now, Anna also had a decreased right lobe transparency on her chest X-ray, and she had pleural effusion. On her abdominal ultrasound, she had ascites, and her cardiology workup showed ventricular dysfunction, left ventricular dysfunction, and increased troponin. So Anna is an overall very unwell-looking, cardiorespiratory unstable 1-year-old child. Brian had, on the other hand, normal chest X-ray. There was only a small amount of fluid in his hypogastrium on the abdominal ultrasound. He had a mild sinus tachycardia and unelevated troponin. And Clara, she had also normal chest X-ray, but there was a free periintestinal fluid and liquid content in the colon described by the ultrasonographist, and there he was tachycardiac, but he had unincreased troponin. So now comes the time for our first poll question. So which of these children do you think is not a MIS-C patient? Okay, guess we wait for the results. Interesting. So let's move on. I suggest we move on straight away with my next poll question, because this was more or less a guessing game because you did not have all the information. Now, what tests or test is missing to establish or exclude the diagnosis of MIS-C? And we have heart MRI, microbiology, or serum IL-6. Okay, very good. So we now see that 50% of our voters opted for microbiology and almost the same percentage voted for serum IL-6. So let's move on with the presentation. So as we know, one of the diagnostic criteria is the exclusion of other infectious cause or other obvious cause of the problem, of the symptoms that the child is displaying. And we have not mentioned any of the microbiology cultures. So while Anna and Brian both had negative samples from all the cultures that we sent to the lab, Clara eventually tested positive for Salmonella enteritidis from her rectal swab. It is a typical course of Salmonella sepsis, except of the rash, of course, but we can discuss this later. Next slide. So for the treatment and outcome of our children, now that we know which child is not a MIS-C patient, we can now say that Anna is a severe MIS-C patient, whereas Brian was a mild MIS-C patient. So Anna was treated with a single dose of high-dose IVIGs, 2 grams per kilo. She also had to receive pulses of methylprednisolone because her fever relapsed on the second day after 24 hours of the IVIGs. She was tapered via lower dose of methylprednisolone and then oral dose of prednisone to a total of 14 days of steroid treatment. She received a combination of antibiotics, fluid and mineral support, ionotrope, and also anticoagulation agents and anti-clotting agents, aspirin and enoxaparin. Despite the relapse, which resolved with the addition of steroids, She achieved full recovery, and I now follow her for the 7th month, and the follow-up is uneventful. She spent a total of 15 days in the hospital, out of which 10 were in the ICU. Brian, our mild case of Miss C, received 1 dose of high-dose IVIGs. He also received a lower dose methylprednisolone and then taper over oral prednisone to a total of 10 days. He received aminopenicillin and also anti-clotting aspirin. He achieved prompt resolution of the fever and full recovery, and on a 6 months follow-up, he still remains well and healthy. He spent 7 days in total in the hospital, 2 of which were in the ICU. And our Clara, with enterogenic sepsis, she only received antibiotics and fluids. She suffered 5 days of remitting fever, but achieved full recovery and requires no follow-up. She spent 6 days in the hospital, and 2 of those were in the ICU. So these were our 3 cases, which I hope will spark some interesting discussions later on. And with that, I shall finish my presentation, and we'll move to the next presenter.
Good afternoon, everyone. So I start with my conflict of interest. So some of the funded research I made here presented. So next slide. So I like first to highlight the surveillance we did in France at the very beginning of the pandemic of these Miss C cases occurring in last May. And actually all the pediatric community participated to this declaration, and all the new cases identified were reported and centralized, and we managed to follow up these first cases at the very beginning of the epidemic of Miss C. So next slide. During the first 2 months in June, we were able to report on 160 patients, and on them about 95 were considered as a confirmed diagnosis of Miss C. And next slide. We specifically looked at 2 different things in terms of epidemiology of the cases. We looked at and compared the cases to the COVID-19 hospitalization at the same time. So on the left, this is in the whole population, the number of cases reported with hospitalization for COVID-19. Actually, it's mainly adult patients. And on the right, there were these Miss C patients, and there is some overlap in terms of spatial distribution, suggesting the link to COVID-19 at that time. Next slide. And we also looked during the time the temporal link to COVID-19. And as you can see here, on orange, it is the number of COVID-19 hospitalization. It is this is not the same scale. So this is 1,000 number of patients reported each week. And in blue, and on the scale on the right, this is the number of Miss C patients occurring from April to May. And at that time in France, there were the lockdown. So as you can see on the orange curve, there is a slight decrease of the number of hospitalization of COVID-19 patients. And there is this same shape of the curve for the Miss C patients, but it is delayed. It is delayed of about 4 to 5 weeks after the circulation of the virus in adult population due to this, associated to this acute severe cases. So next slide. We managed to increase the number of collected samples and patients, and it's probably more near 4 weeks that we have this peak that occur following the infection. So this is purely epidemiological data. But now we know that in a single family, we often identify 4 weeks before the contact with the SARS-CoV-2 or moderate infection in children or parents, and the Miss C occur 4 weeks after. So this is very intriguing to see that there is this specific delay It's not 4 months after. It's not at the time of the infection. So probably there is something occurring on the adaptive immunity at the time of the persistence of the antigen that is necessary to develop this specific inflammation. Next slide. So here, this is the up-to-date follow-up. So as you can recognize on the left, this was the first peak in orange of the hospitalization, and then the first peak of MIS-C patients, and then the lockdown. We were quite fine during all the summer, and since last autumn, this is still quite present and maybe less clear for the shape of the epidemic. We have still sporadic cases coming up every week in France, and we expect now, with the decrease of the number of hospitalization, that normally MIS-C should decrease in 2 or 3 weeks now. Next slide. So I realized that I have missed some poll questions. So I don't know if we can still have this question now, or if not, it doesn't matter. So regarding, yes, so no, this was for the first presentation. So you can still answer, but you have now the solution. So the timeline of COVID-19 and MIS-C, I'm sure you will all give the good answer, which is 4 weeks. So that's very good. And I don't think it can occur at any time. I don't believe this. I really think that there is a need of these 4 weeks, about 4 weeks, and it never occurred 6 months after the COVID-19. I don't think so. And the next slide, the next poll question, maybe, it is about the pathogenesis of MIS-C. So next poll, if possible. So considering the difficulties to diagnose the 3 cases that have just been presented before. So for you, what's the most specific marker of MIS-C? The I-D-dimer, increased troponin level, the expansion of TCR-V beta 21.3 in T cells, or the specific increase of monocyte HLA-DR, which is an activating marker of monocytes. What is your opinion? I'm happy to see the results. Yes, very good. That is quite specific, and I agree with you. So next slide, we can go to this study. So we and others work on the specific pathogenesis of this disease, which is very intriguing. So initially, we thought, I am a guy working on lupus and interferon. So I thought that there were an increase of interferon in this patient. I thought that in pediatric practice, there is this matter of, they are mostly asymptomatic, maybe because the pediatric population can produce a large amount of interferon. We know that interferon is critical for the pathogenesis. And then some of the patients maybe present high level of type 1 interferon and then can develop an inflammatory disease. But in this work, we looked at the type 1 interferon, so the level is totally normal. So then we felt that maybe it's something else. It's not related to type 1 interferon overexpression in these patients. So we looked at T cells. And next slide, we actually identified, as you can see here, that about 75% of the patients display an increase of this subset of TCR-V beta 21.3, which is the protein expressed in the V beta of T cells. We find this expansion of T cells. So we can look at this by protein or by RNA, and the RNA coding for this protein, this is a TRBV11.2. And we looked at different populations we had in the lab and in the hospital. And we found that this is very specific. We can't see this expansion in other mimics of this specific inflammatory disease, not seen in KD, not seen in COVID-19, even not in toxic shock syndrome. As you know, in toxic shock syndrome, it is the V beta 2, which is mostly associated to streptococcal toxic shock syndrome. And here we feel that this is quite specific of MIS-C, and I'm sure now we and others are working to identify what is the cause of this specific T-cell activation, which is quite transient because 7 days after, there is no more expansion. These cells are highly apoptotic, actually. So this is very intriguing, and I guess this is a marker we can use by fax and get the results in the same day. So thank you. I let my colleagues follow up with the discussion.
Hello, everyone, and thanks for asking me to join this meeting, and thanks for beautiful clinical presentations and for a lovely overview of the immunology from Alexandre. Can I have the next slide, please? So I think we heard in the cases that were being presented that there seemed quite a lot of certainty that patients with MIS-C should receive immunoglobulin with or without steroids. But I think that there is a big difference between committees sitting around and writing guidelines based on what they think should be happening and having definitive evidence of what treatments work. And I think, as everyone on this meeting knows, the only certain data of what treatments work is data from randomized placebo-controlled trials. And clearly, as this was a new disease, it was evolving very rapidly after the early months of last year. It was very unlikely that we would have data from randomized trials quickly. And so we set up an international study beginning in April last year, in which we had the view that if clinicians all over the world could enroll their patients wherever they were and record accurately the clinical features of the patient and the response to treatment, and treat the patients with whatever their best guess was of what would work, and we knew some clinicians were using immunoglobulin, some were using steroids, some were using biologicals. We really didn't know what would work. And we also knew that many countries, particularly in low and middle income countries, had no availability of IVIG or biological. And we therefore felt it was important to try and gather the information of what individual clinicians were choosing to treat their patients with. And so the BEST study, Best Available Treatment Study, is an online enrollment of patients. It was open to clinicians anywhere in the world, and all they had to do to join the study was to log on, receive a study number and details, and they could then enroll their patient with detailed clinical information on the patient and also what treatment they had given for the patient. And the idea was that although this isn't a randomized controlled trial, the statistical method of propensity matching would allow us to correct for any imbalance in the severity of the patients and therefore be able to compare the different treatments that were being used. Next slide, please. It has been a remarkable indication of the willingness of pediatricians all over the world to collaborate and to share data on this newly emerging disease, that we had 35 different countries joined the studies, with over 150 centers making up the population of patients recruited into the study. So I'm only going to present in very briefly the first results of the first 600 patients enrolled in BATS. We have now got more than 1,000 patients enrolled, and there will be further analysis as time goes on. Could I have the next slide, please? So the results of the first 650 patients were published in the New England Journal with Andrew McCardle and the group at Imperial as the first authors. And can I go back to the previous slide? When we looked at the different treatments that had been received by these first 600 patients, there were three main groups. 246 patients had received immunoglobulin alone. A smaller number of 99 patients were treated with glucocorticoids alone. And then there were 208 patients who've received a combination of immunoglobulin and glucocorticoids. And then there were a whole range of other treatments that were given. And there were also a group of patients who recovered without any immunomodulatory treatment. Next slide, please. So the primary outcome of the study that we chose was a composite of the progression to requiring inotropes or ventilation or death by day 2 after commencement of immunomodulatory treatment. And the second primary was improvement in an ordinal scale ranging from very severely ill patients who were on ventilators and requiring inotropes down to patients who were discharged from hospital. And you can see the full details of the ordinal scale on the published paper. And this is a forest plot showing the odds ratio of immunoglobulin plus glucocorticoids versus immunoglobulin alone. And what we can see is that there were no significant differences in the primary endpoints in favor of either of these two treatments. On sensitivity analysis, which included the first and second day of treatment with immunomodulators, there was also no significant differences. There were a whole number of secondary analyses, and the only one that was a significant difference in favor of combination treatment was the escalation to additional treatments. And this may not be surprising, because if you start off with 2 drugs rather than 1 and the patient is doing well, there would be a great, not doing well, there would be a great likelihood of adding in a second treatment. And on all the other markers, there were no significant differences. The odds ratios between the 2 treatments crossed 1. Next slide, please. When we compared steroids alone versus immunoglobulin, again, on the primary endpoints, there were no significant differences. And the main difference, and the slide has slipped a little bit, but when we restricted the study to only patients meeting the WHO criteria, there was a statistically significant benefit in terms of the improvement in severity in those receiving steroids rather than immunoglobulin. On all other markers, there were no significant differences between the 2 treatments. Next slide, please. When we looked at the improvement in the inflammatory markers, we looked at the rate of decline in CRP, troponin, and ferritin. We first compared patients who received no immunomodulator treatment, shown in blue, with those who received any of the 3 immunomodulators, and we could see that there was a more rapid improvement in CRP in those patients receiving an immunomodulator. But when we compared the 3 different treatments, glucocorticoid alone, immunoglobulin, or the combination, the rates of recovery were very similar between the different treatments. Next slide, please. So in summary, this attempt to compare immunoglobulin alone, steroids alone, or combination has not shown that any of the 3 treatments was statistically more significantly better than the other 2. There were no significant differences in the rate of improvement in organ failure between immunoglobulin and steroids, or immunoglobulin and steroids combined. We saw a suggestion of a more rapid improvement in patients receiving steroids or steroids combined with immunoglobulin than immunoglobulin alone. But I must stress that there was insufficient data to say with certainty that steroids are equivalent to immunoglobulin. And the main reason for this is that one of the main reasons that clinicians have given immunoglobulin is because of concern about coronary artery aneurysms, and as you know, immunoglobulin is the proven treatment for Kawasaki disease. There were insufficient data on follow-up coronary artery aneurysms to show that there was not an increase in any of the arms. So I think we have to have a note of caution. But the overall conclusion is that we could see no difference in outcome in the rate of recovery from organ failure or development of organ failure between any of the three major treatments. Next slide, please. So the study that we've reported in bats has appeared simultaneously with a study from the United States by Son et al. And also by the French collaborative study, which was published previously in JAMA. And it is worth pointing out that the bat study, which did not find any difference between the treatment arms, has a slightly different conclusion to the other two studies, which did find less cardiac dysfunction and in patients receiving combination of steroid and immunoglobulin. So I'll end by saying that what these studies have done is highlight that we still don't know what the best treatment is. It looks like any of the immunomodulatory treatments will work to switch off the inflammatory process. On the whole, as was highlighted in the presentations, there is a very high rate of recovery from the disease. But as to which of the treatments is preferable, at this point we have to say we're really not certain, and we are awaiting larger numbers of studies in the bat, patients in the bat studies, and also the results of randomized study, which is currently in progress in several countries. So I know time is short, so I'll end by passing on to the next speaker, and thanks very much for the opportunity to present this data. And obviously to thank all the collaborators on the BAT study, which has been an enormous tribute to international collaboration, and all the my colleagues at Imperial College and this large list of collaborators from countries all over the world. Thank you again.
Okay, good evening, everybody. My name is Sediva, and I am going to show you very shortly some of the outcome of this really new disease, which I am sharing the excitement with other speakers to talk about today. I have my, some interest. Next slide, please. Yes, and I am using the example of our first patient, which showed in our hospital last year when the disease was completely new and we did not know what actually it is, and we were monitoring closely. And I am using this patient only as an example to show you the very fast dynamic on the acute phase. As you can probably see CRP and other inflammatory markers, and it really lasts only several days, and the inflammation, which really characterized with the severe period, comes down and never shows up again. So the short-term outcome is just now known. It was also documented by previous speakers, and the outcome, in contrast to the severity of the disease, is really good. The mortality is low, and actually, can I have the next slide, please? Yes, and then if you come to the mid and long-term outcome, it is really not so that well known as the short-term outcome, and we were somehow seeing many patients after the waves of COVID-19 in the spring this year, and we realized we do not have enough information how to follow them and what to advise to the parents and what the long-term outcome could be expected. So with Markéta, we came with this table showing some guidelines or some rules what to do with the patients next when they are discharged from the hospital. And I must say the outcome really shows to be very good. We came with some design for follow-up in 2 weeks, and then later in 3 months, 6 months, and 12 months. And the base for the follow-up is definitely cardiology, because heart is really the crucial organ which predicts the outcome. And the next, what is the follow-up is immunology or rheumatology for monitoring of inflammatory activity. And all these follow-ups are important for providing the information for parents and for patients how to deal with the therapy. Cardiologist deals with the aspirin therapy, and the rheumatologist and immunologist provide some direction how to taper steroids and how to deal with the patient on long-term basis and how to manage the vaccination. Actually, these children all received high dose of immunoglobulin, so these attenuated vaccines may be offered after 1 year when they are discharged from the hospital. Of course, all these checkup points are completed with laboratory assignment, and it is mostly looking for these inflammatory markers. But as I mentioned before, this inflammation is really very typical for the acute phase and is not coming back in the later stages. What's really very challenging when you follow these patients is the multitude of specialties which are involved in the management of these patients, and it really poses this logistical challenge, which is really shared by all publications which I read on my study and preparation for this presentation. Next slide, please. Yes, and later on, just about 1 and 2 months ago, came the manuscript from Switzerland, which was already mentioned during this previous presentation, which describes the best practice recommendations for the management of children with MIS-C. And this really nice manuscript includes also the long-term outcome. And as you see on the table, it is very much similar to the table we decide, and shows the periods for follow-up in 1 or 2 weeks, 4 to 6 weeks, 3 months, 6 months, and 12 months. It's very much copies what I said before, but they go to more details, and they recommend a different follow-up for children according to the degree of their cardiac involvement. Of course, some children with mild MIS-C will drop from follow-up at 3 months, but the most severe cases, they need really follow-up up to 12 months and maybe even later. Next slide, please. And this is basically my last slide, and it shows the outcome from the really nice study from London, from Ghent Pediatric Hospital. And they were following their patient for 6 months with multidisciplinary follow-up, and they somehow picked very nicely their results on one slide. And you can see on the first view that at the baseline, the disease is characterized by really severe inflammation. But actually, already at 6 weeks, this inflammation is gone, it's never coming up, and there are only some residual problems with the children. And at 6 months, it's even better. And as you see, at the 6 month, only these blue dots are mostly remaining as the problems, and these blue dots, they point to neurological findings. But also the authors of this paper, they state that the persistence of subtle neurological findings is really mild, and these findings are noticeable only when you provide a detailed neurological examination, and usually they do not correlate with really severe neurological impairment. And we really remind us this long stage, something about the long COVID, and we are a little bit afraid we are going to see these patients with kind of chronic fatigue. But anyway, we consider that to be normal. These children went through very severe inflammation and very severe disease, and actually the recovery might last longer. But basically, most of the children are back to school within several weeks, and we find the outcome of this disease to be really excellent in comparison to the severity of the initial presentation. And to conclude, I have one last slide, which is actually the poll slide. Can we have it? Yes, and it's just very, I would say, obvious. Which specialist would you refer to follow up your patient after MSc? Immunologist, rheumatologist, cardiologist, neurologist, nephrologist, all above or something else? Yes, I think it was really very obvious, because in all publications I read about it, and even from our experience, it is multidisciplinary team who should look after those children, because they have really very heterogeneous presentation. So it was really a nice and short overview of the outcome, and I'm very pleased that the outcome of these children is so nice. Thank you very much, and I pass this presentation to the other speaker.
Oh, thank you very much, and I thank you for the kind invitation. Since we are running late, I think that I'm going to present this very quickly. Is just to make you aware of an initiative that is in a way overlapping on what we have heard. Can you go on? Okay, this is an international initiative that raised from the European Reference Network, RITA ERN, that, as you know, is related to the inborn error of innate immunity or adaptive immunity. And we are, next slide, please. Oh, no, nothing to discuss. Go on. Okay, so we were asked at the level of ERN to make a sort of, let's say, initiative to understand the relevance of this phenomenon of MIS-C in children, taking for the institutions and also the society that are taking care of patients with rare immunological features. The next, please. So when we start the project, there was many national initiative registry ongoing. First reports have been already reported, and there were plenty of initiatives like pathogenic initiative, or also like the bats, the incredible bat study that we have learned a few minutes ago. Before. Can you go on? Okay, the plan, of course, of this approach was not to overlap with all the national and international research activity, but the idea was to build a large European initiative that helped an homogeneous collection of demographic, clinical, and outcome data among all the societies and the centers that are linked to ERN RITA. The next. So we try to make a new stuff in terms of a way in which different society, let's say, collaborate all together for a unique registry, maybe on different platforms, but with a single and unique forms and approach. That's why different representatives from RITA ERN, but also from ESID Press, ESID, and with the help of Printo, that is a large network that is working in the field of autoinflammatory disease and pediatric rheumatology, design the registry, the forms that are online forms that are already available on the Printo network. Go on. And of course, there are, and you have heard about a number of already ongoing initiatives that are starting to give some idea in different countries. Some international, like the BATS, are also ongoing. So far, we have some information on some countries in Europe and the United States. The next, of course, the idea is to try with this approach to have an homogeneous picture of the problem among the different European countries, in the western part, eastern part, and maybe also in other parts of the world. The comparison among different regions in Europe and outside Europe for different health system, economical level, and so on. To have, as Anna pointed out, some important point of relating of long-term follow-up, and also a possible potent tool for further study on European levels also taking into account the possibility of funding of European reference network on this specific topic. So having a big registry on that collect patients on the European level can help a lot. Avanti, next. The process is much more complex. It might take much more time because we follow the typical and the traditional way. We search for all the different centers that have to apply to the ethical board. Of course, we help in all the problems related to the ethical boards, because for this registry we want to have the consensus of the patients, and this should follow absolutely the rule of good clinical practice. Even if the patient, of course, are anonymized, we do think that we need to have informed consent, because we want to go into detail to many aspects of the disease. So this takes time, and this is good because we want that, of course, all the national initiatives are of course well developed and finished. So these are the number. Of course, the patient, now we have today I check 280 patients enrolled, 42 centers open, others that are going to open. The next one, and the next one, please, and go on. And we understood that there are also a lot of extra European countries that want to participate and that are submitting the process to their ethical board. And the next one. So this is a big initiative. This is already working in the field of pediatric rheumatology, autoinflammatory disease through the Printo network. It will be also possible to start the collection, I hope soon, also from the ESID part, because ESID decided to have a parallel, let's say, collection of the data in a parallel way, but then to merge the data because the registry are done in the same identical way. So in conclusion, we have an international registry of MIS-C. It's one of the international registries. This is a European registry. First initiative that linked together all the different society. I think this is very important and is a new approach. We hope to have an homogeneous data across Europe and the rest of the world, and to have many interesting data on long-term follow-up, and also to merge maybe with the previous national initiative. We are working a lot with Italy, French, Alexandre, to try to merge what is already in their national registry. Thank you very much indeed.
Thank you very much, all of you, for this very nice presentation. And as we are running late of time, it's just representing that we have so many and so much to say. But I hope that I can convince the participants to stay for additional 10 minutes with us, to have an interactive discussion based on the questions that we receive. So thanks again. Can everyone switch on his camera? And then the first question is from Andy January, who asked if there is a similar syndrome evident in adults. Can someone comment on that? So maybe, I don't know if Mike can answer that comment on, because we only discuss children.
Yeah, thanks for the question. There have certainly been reports of adults presenting in cardiogenic shock following SARS-CoV-2 with all the same inflammatory features of high troponin, myocardial depression, high ferritin, and also responding well to immunoglobulin or steroids. So I think there's definitely an adult equivalent. There is also a lot of interest in whether the inflammatory phase of COVID itself, which is also associated with high CRP, high troponin, multi-organ involvement, may have some similar immunopathology. Interestingly, with Alexandre's very clear description of MIS-C happening 4 weeks after the peak, whereas adult disease inflammatory phase happens at about 10 days. And one could speculate that in children we're seeing a secondary immune response which takes longer to develop, but perhaps adults who've had years of exposure to coronaviruses may have a primary immune response, but this is speculation. But yes, there certainly is an adult disease of equivalence.
Okay, thank you for this comment. Do you want to comment, Alexander, on this, or can? Yeah.
Yes, the oldest patient, cohort is 30 years old. So just probably in young adults, there is mimics of this MIS-C. This is called the MIS-A, and I definitely think there is the equivalent in adults, as Michael said.
Okay. Thank you. Then, before I will leave the question on the vaccination at the end, but first let's go further on the treatment. So we discussed and we presented nicely in the BAT study and also other studies, IVIG and series, but there's a question on biologicals and what about the place of JAK inhibitors in the treatment of MIS-C? I don't know if maybe Marco can comment that.
Yes, of course. It was also a question that I would like to to ask to Michael and also maybe to Alexander, because of course this is relevant. As you know, there are plenty of anti-cytokine treatment that has been used in the lung COVID disease, in which the effect is still questionable, and we still do not have a final reply on the effectiveness of this anti-cytokine, even with JAK inhibitors. The same could be even more for the MIS-C, of course. That is a typical prototype of a hyperinflammation, a cytokine storms after let's say, immunological triggers. We personally use a lot as a rheumatologist anti-IL-1 blockers because we think that is very effective. And indeed, this is a very effective also in COVID-19. There is a recent meta-analysis and a recent clinical trial on the adult COVID that's showing that indeed the early use of anti-IL-1 blockade could be very effective in the phase in which the inflammation is so high. So we use a lot anti-IL-1. I would like to ask, just to have a common discussion, and and then I finish with the JAK inhibitors. The question for Michael and Alexander and for the others is if you think, and also in the experience of your registry, if there could be some place, you understood some place for anti-cytokine treatment. For JAK inhibitors, and I finish, of course, there is some concern of the anti-interferon response. You know that a possible reduction of interferon could be deleterious at the beginning in the pulmonary, a very severe lung disease. We don't know in MIS-C. My idea that JAK inhibitors are very good anti-inflammatory drugs, and that should be absolutely good also in MIS-C, theoretically, and not harmful. And I would not be, of course, worried to use JAK inhibitors in this condition. Of course, there is no evidence, of course, and I will prefer much more a drug that I know much better, that is anti-IL-1 in this case. But I leave to the others the comments.
Thank you. Mike or Alexandra, do you want to comment this?
Well, thanks. As I think is happening everywhere, for patients that don't respond to one treatment, we often move to treating with biologicals if they haven't responded to steroids or immunoglobulin. And I think this has been the practice everywhere. As far as the BAT study goes, the numbers of patients treated with individual biologicals has been too small to yet do an analysis. And so we will only be able to answer that question with any data once we have looked at much larger numbers. The pediatric recovery trial, which is ongoing in the UK and is now extending to a number of other countries, is randomizing patients to anti-IL-6 and as well as steroids and immunoglobulin, but the numbers treated, I think, are going to be too small. So we really are going to need more data before we can say for certain that anything works. And I'll just leave the thought that if you'd asked me some years ago, should we give fluids to patients in shock, I would have said, of course, we're certain everyone gives fluids to shock patients and they make a difference. And then we did the FEAST trial in Africa of giving modest amounts of saline to children who were shocked, and we found that we increased mortality. So I think we can think that we know that biologicals work, but until we've got some data on a big enough scale from something that is close to a randomized study, we won't be certain. And I think we need to keep that critical thing that we really need to gather more data before we'll be certain about it.
Sure.
Alexandra, thank you. Alexandra, can I continue with the question? Another question, what is the longest period of anti-IL-1 treatment in any patient with MIS-C? Do you have experience with that? These are some other questions that we have here.
I think Michael has already answered this. Indeed, for patients resistant to IVIG and steroids, we treated some of them with IL-1 blockers and with nice results, but it's hard to say whether or not it is recommendable. But in terms of totally thinking to the pathology of the disease, I just want to highlight that indeed there is this cytokine storm. So inhibiting these cytokines seems to be correct, and it's difficult to pick up one among others. I think the JAK inhibitors are interesting because you can cut a lot of different signaling, and there is one report on a SOX1 deficiency that presented a very severe MIS-C. And as you know, SOX1, this is the natural JAK inhibitors we all have. We describe these deficiencies in lupus patients, but it seems to promote also this specific hyperimmune inflammation. So maybe some of the patients display a polymorphism. I don't think this is a hit in the genetic data right now, but anyway, in terms of JAK inhibitors and MIS-C, that's an interesting point. But of course, we need additional data. And
first, sorry, if I can add, just when you consider a drug, you have to also to consider how fast is the drug to start working. And so you have to understand, and how is easy to manage the dose and the response very, very easy. So it's a very important and difficult question that we have to address for sure.
And another question on these drugs, do you all measure cytokines in these patients? Would you recommend that before you start the treatment? It's a short question with a short answer. Yes or no? Do you perform?
Yeah, I would say no. It was just, we did it on the research basis, but I don't think that we are enough in advance to select one cytokine inhibitors with the cytokine level, definitely.
Yeah. Maybe, Anna, can you answer a question by Shoban that, so if you have a patient with HLH presentation with prior COVID, do we consider that this as a MIS-C or as HLH? Or is that not clear? Can you comment that? You're muted.
I am muted. I think Markéta can comment because she has personal experience with such child. Yeah.
Okay, so this maybe this is not going to be a direct answer to that question, but perhaps I will present more of a question to you, because we were treating a couple of weeks ago a 3-week-old newborn who contracted COVID-19 from his mother and developed high-grade fever, developed high inflammatory parameters, and actually developed shock-like symptoms. But eventually also ended up fulfilling the criteria for HLH. And this was extremely difficult for us to then decide how to treat this child, because with such a small child, first of all, it could be primary HLH. It could also be a COVID-19 associated HLH. There are reports of such event in the literature, individual cases, but there are, and it doesn't have to necessarily present as MIS-C. But then also there are reports of MIS-C patients eventually showing signs of hemophagocytosis in their bone marrow. So I don't think we have a clear answer for this, and it's always extremely difficult to differentiate. And the reason why we have to get this right is to treat the child right. So in actual fact, we ended up treating this child with IVIGs, with immunoglobulins, and then only steroids. We did not follow we didn't have to follow the whole protocol for the HLH because this was sufficient, and the child recovered. The fever regressed, and this was all.
That's very nice. So we need to be aware on if HLH presentation can be treated as a MIS-C patient. And the last burning question is, is on vaccination. So we received many questions on that. Should we, so the first is, should we vaccinate MIS-C children? So children who had a history of MIS-C, and in many countries, children are already indicated to be vaccinated, so between 12 and 16 years old. Should we vaccinate? Should we wait for 6 months, for 12 months? So yes, we kept this burning question for the end of this session. Who wants to kick off on this question? Alexandra, and one is a question, is there a risk to reactivate the T-cell clones responsible for the MIS-C? Because this is the reason why we are so afraid of vaccinating the children. So this is one question.
Yeah, I think this question is very important, and there is, considering the vaccination, we don't know whether or not the vaccination can protect against MIS-C. That would be really wonderful, but we have not the data right now. And in France, so for the last months, we can now vaccinate the 12 to 16 patients. And Alain Fischer, you know, all of you know, this is the vaccine man in France. He said, he said we shouldn't vaccinate the patients with MIS-C because this is a precaution thing. We don't know, we have no ideas, but by precaution, we suggest not to vaccinate them. But because first, they have antibodies, and this is highest than adults. And then, in terms of global epidemiology, this is only 600 cases in France. So we can recommend not to vaccinate them, and it won't be a matter for the population. And there might be a risk because we can activate this specific clone we have seen after the SARS-CoV-2 infection. And as we don't know, it's probably wise not to vaccinate these patients, especially because we know also there is this myocarditis in some of the patients. This is mild myocarditis. There is no PIMS seen after vaccination, but anyway, there is this information, and we need additional data to recommend this on MIS-C patients.
That's very clear, and I really appreciate also the work from Alain Fischer in this recommendation on COVID vaccination. Are there some other panel members who have an opposite advice in their country, or do you share the same advice not to vaccinate children with a history of MIS-C, which is a conclusion maybe?
I think I would certainly agree completely with Alexandre that we have a real concern that whatever the trigger and the target of the immune response in MIS-C is, we may reactivate it by vaccine. And the reports of myocarditis after Pfizer vaccine in the United States and Israel are worrying that there is something cross-reactive in spike protein to some host tissue. And I think knowing that the MIS-C patients have cardiac dysfunction and inflammation, knowing that there is a group of patients who get myocarditis after vaccine, it seems that we need a little bit more information before we give another dose of an antigen, which may trigger either a T-cell or an antibody-mediated response, which somehow cross-reacts with the heart. So I agree completely. We should hold off until we understand a bit more about what the antigen is.
Yeah, Marco.
I agree, absolutely. I wonder, and this just for sake of discussion, and what could happen with the variants and with the decrease of the possibility the decrease of antibodies if this subject meet again the virus, maybe another strain of the virus. Can we figure out what could be the outcome?
Mm-hmm.
One can speculate that it already occurred because the virus was still circulating, and there is no double MIS-C in any patient, so suggesting that at least the antibodies were protective with the souche that are on the place.
I agree, because they also, most of them, they have antibodies. They seem to be really long-lasting and protecting, so we probably do not need to vaccinate them.
Okay, so can we conclude on the vaccination? We do not recommend to vaccinate patients with a history of MIS-C, but on the other hand, we will recommend patients at risk, so patients with errors of immune disorders, to receive their vaccine. So it's really a difficult balance in between, but we also are convinced that we need to recommend these patients to receive their vaccine. So still many questions on vaccine, but I think that almost we are running so late, but this is really an interesting discussion. I think we can close this session. I would like to thank all the panel members. It's clear that we had all the experts on MIS-C here all together, so it's really great to have you all here together. I also want to thank the participants who were joining us even later on than 1 hour, so thanks again. I would like to thank the organization, the ESID and Ghent, for supporting us. And so we would like to invite you to the next webinar, which will be after summer holidays. So enjoy your summer holidays, and thank you for joining us. Bye-bye.
Thank you very much, Filomeen.